All right, well, good evening, everyone, and thank you so much for coming over to visit with us and listen a little bit about bariatric surgery and the surgical care of obesity. So what I'm going to do, and try not to keep you here for too long or too bored, I'm going to talk about different topics, and I have just basically given an outline. I'm going to let you know who I am. I'm going to talk about the problem of obesity. I'm going to talk to you about the impact of weight loss surgery on the patient's lives, explain to you why I do weight loss surgery, and explain the types of surgery, and finally, what we're going to have to do so that we can get you to surgery. So hopefully with this outline, we'll be able to follow at least a plan. Patients usually want to know where my accent is from, and I usually just want to let everybody know I'm originally from Mexico. I was born and raised in a city called San Luis Potosí, right in the middle of Mexico. My family still lives there. My father and my brother are cardiologists there, and I still go back and forth and visit my family there. It's actually approximately an hour and 45-hour flight. There's a direct flight here, so I stay in touch with Mexico very much, and that's where the university or medical school that I attended in Mexico. You know, I know that you all have a lot of options of surgeons that you can go visit and have your surgery with. I think there are a lot of very qualified surgeons, and I definitely believe that I'm very qualified to take care of you and to do a very good and caring job with your bariatric or surgery weight loss journey. Basically, I'm board certified and recertified by the American Board of Surgery as of 3 years ago that I received my recertification. I'm board certified in general surgery in Mexico, and I'm actually a fellow of the American College of Surgeons as well. In addition to that, specifically related to weight loss surgery, I did my training in University of Texas Southwestern in Dallas. I'm a fellow of the American Society of Bariatric and Metabolic Surgery, and I'm considered a center of excellence for weight loss surgery. Basically, what it means is that the American Society for Metabolic and Bariatric Surgery has given this designation to surgeons who have demonstrated excellence in the performance of weight loss surgery, resulting in safe, high-quality surgery meeting standards set by this society. And in the future, this Center of Excellence is going to turn into what is called the Accredited Center as Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. My office, NHSA, or our surgical group, as well as the hospitals in which we perform the surgeries, for the most part, have received this designation. And at this point, I'd like to say that I have unrestricted privileges to perform this bariatric surgery in at least 7 hospitals in Houston. Let's talk a little bit about what the problem of obesity is. I could spend an hour or 2 hours just talking to you about the obesity epidemic and all the problems that it causes. Basically, what I'm going to tell you is that in the last 20 years that we're looking at here, we have seen how obesity has increased twofold in adult patients, 3 times in adolescents, and we're actually seeing how even the epidemic within the epidemic has become evident, because now we see that the patients that are obese are 4 times, the morbid obesity has increased 4 times, and we're seeing that patients are more obese than they used to be, or patients are heavier than they used to be. And you can also look at this data when you look at these images and you start to compare different countries. When you look at countries that seem to be very civilized, in which you would expect that the weight loss or the weight hasn't been so significantly increased, you still see that over the last 50 years, the United States obviously has been the leader in terms of the percentage or the growth in obesity patients, but you can also see how all the other countries have noticed the same type of growth in which patients or the population is heavier, continues to be heavier all the time. And the main concern of obesity is that it actually affects in different aspects of the patient or the population. One of them is that it can be a disabling condition. Second, it increases the medical costs. Third, it results in a reduced quality of life. It can actually result also in premature death or early mortality. And finally, the main thing or the main reason why we're worried about is because obesity, it's also the cause for many additional medical problems that we're going to be calling here comorbid diseases. And when you look at this, you can actually see that if I just chose all these different medical problems that are associated with obesity, you can actually see how some of the ones that I have highlighted seem to be very common and are associated with obesity. Some of these are diabetes, high blood pressure, lipids and cholesterol, heart disease, but even depression and certain types of cancers have been associated with obesity. So what's the point of me telling you all this? Why I could go on and on with all statistics and all the relevance in the different type of problems and different type of illnesses. But why do I tell you all this? Well, it's the same reason why I want to tell you why I perform weight loss surgery. So the reason why I do the weight loss surgery is because I see the impact of the weight loss surgery on the patient's lives. And what I've seen, and the literature reveals, is that all these medical problems that are associated with diabetes, of which, again, you see at least 4 of them highlighted, all of these illnesses actually respond to weight loss surgery, and the condition or the problem can actually either improve or significantly be resolved. Some of the things that we see also is that the quality of life is improving 95% of the patients, and the relative risk of mortality is actually decreased for almost 90%, by almost 90% in the first 5 years after the surgery. I also do weight loss surgery because I see patients change their lives, and I see how patients are so happy. This particular text, I decided to print some of my texts instead of just deleting them, and I'd rather share them with people, as I find that this may be something that motivates the patient to have surgery in the future. I put on a pair of size 8 jeans yesterday. I almost cried. I think I came out of the womb wearing a size 12. Thank you, you have changed my life. And just like these ones, I have a good collection of texts, like this one. I can tell you how many people ask and say they want to go see you. I'm a walking advertisement, apparently. And so many other texts that I could show you. I also see how patients' lives can significantly change. And you can actually see how some patients decide to go from certain lifestyle to a very active and sometimes a little bit exaggerated sports activity, like the one you see here. You also see how patients, after these changes, they're willing to share pictures with me, they're willing to be more outgoing, and this actually changes their life. That's why I do surgery. You also see how the body mass index of the patients can actually go from what is called obesity BMI to a normal body mass index. So let's talk a little bit about body mass index. Since I touched briefly on body mass index, let's see what this number means. A body mass index is actually a number that is calculated by dividing a person's weight in kilograms by his or her height in meters squared, or square meters. And this is actually a number that it's a good indicator to categorize weight in terms of what's healthy and what's unhealthy. And you can find and you can look at so many tables in which you'll be able to cross your numbers and find out. I always use my example. I'm 5'10" or 5'9", and my weight is somewhere around 182. So my body mass index is somewhere around 26 or 27. So whether you want to believe it or not, I actually fall in the overweight category. And this is an example where you see some of these. Overweight category is when the body mass index lies between 25 to 29.9. That's where I would be. But as you continue to look and you see how the body mass index increases, you can actually see that patients with severe obesity have a body mass index of 35 to 39.9, and patients who are morbidly obese have a body mass index of more than 40. These patients in the last 2 categories are almost always approved by their insurance companies, are almost always classified as a patient that would require and benefit from weight loss surgery. And just another way to look at body mass index is, you can always look at your phone. You can go to your app store, and you can find different tables in which you can actually calculate your body mass index in that way. And just a couple of graphs just to talk briefly about body mass index. This is one in which the body mass index is noticed here that is, as it increases, you can actually see that the age-adjusted relative risk of contracting diabetes mellitus increases. So you can see on the female patients, the higher the body mass index, the higher risk of having diabetes compared to the male patient. Another graphic just to compare briefly about body mass index. As the body mass index increases, you can actually see how the relative mortality risk actually increases as well. So let's talk a little bit about the obesity treatment. And we can very easily classify the obesity treatment as surgical versus non-surgical. Of course, everybody's here, and we try to meet with patients here because we're particularly interested in surgery. So that's what we want to educate you on. But we're also going to talk briefly about the non-surgical treatment options. And the non-surgical treatment options, we've all tried them before. They have worked in the past for us. Sometimes they work, sometimes they don't. Sometimes they work temporarily, and then you fail and you have to try again because you regain the weight. But all these different recommendations like diet, fitness programs, of which I've just mentioned some of them in this drawing or in this slide, dietary programs, all of these are useful. All of these are tools that can help you improve your weight now or after the surgery. Some of the other non-surgical treatment options include medications. There are new medications that are coming out on the market, and there are some that are going to be very promising. We may be actually using them with some of the surgeries. There are behavioral modifications, and there are also a very large amount of specialized drinks that you can use as part of your journey against your obesity. The issue with all these non-surgical measurements or non-surgical treatments is that even back in 1991, which is 22 years ago, the National Institute of Health decided that when they looked at obesity, 90% of these patients did not lose significant and sustained weight. And only surgery was the only proven effective weight loss measurement over a long period of time for most of the patients. And the one thing that they concluded back then is that these patients would be able to lose 50 to 75% of their excess weight. They would be able to keep it, or they would be able to achieve that within the first 2 years. And they would be able to keep it down at least for the 10 to 14 years in which these numbers were studied. We now know that this weight loss can be maintained for even longer. So at this point, they said, well, let's look at the surgical options. And for the surgical treatment of obesity, is the second thing that I wanted to talk to you. It's specific as which patients are going to be considered for weight loss surgery. Like I told you on the previous slides, when we looked at the body mass index, the first two indications for surgery are the body mass index more than 40 kilograms per square meter. The second one being patients who have a BMI greater than 35 if they have an additional medical problem or comorbid condition like we talked about. This was going to be the basic category in the way that we're going to actually bring the patients to see if they qualify just from the weight, height, and body mass index standpoint. In addition to that, they need to have had history of failed sustained weight loss, unsupervised weight reduction programs, and some insurance companies will require that you can document that the obesity has existed for more than 5 years. Now, in addition to that, which have been the criteria for all this time, we now have some new criteria that have been proposed by the International Diabetes Federation. This is an article from last year, after meetings from last year, in which now, in addition to all those criteria, to just those criteria that I showed you, now they're willing to consider patients who have a body mass index less than 35 under certain circumstances. They're willing to consider patients who have a hemoglobin A1C, which is elevated, which is usually the case of the diabetic patients. And usually the number that they've used is 7.5% or greater. And they're also willing to consider weight loss surgery in those patients who have failed to improve their medical condition like blood pressure, lipids and cholesterol, obstructive sleep apnea with medications alone. They feel that losing weight and assisting them with their weight loss with surgery will also improve these conditions. So these are new criteria. We're going to see more weight loss surgery done under these indications in the future. So at this point, what I want you to know the types of surgery that we can offer and that we can do, because that's ultimately what you want to be educated on when you come to these seminars. The first basic principle that I want to tell you is that the reason why this surgery has become so popular and so successful is because everything that we're doing with minimal invasion or with a laparoscopic approach, which actually means that at the end of your surgery or your procedure, you will end up having somewhere between 5 and 6 small incisions in your abdominal wall as opposed to big incisions in your abdominal wall. This will result in faster recovery, less pain, and just a decreased risk in complications as well. This other picture may be a little bit graphic for you, but this gives you an idea that we use these trocars, these entry sites, to insert instruments like cameras, gas, and some of the instruments that we use to perform the operation. And all of these procedures, gastric bypass included, are done usually through this approach. So let's talk about what the options are in terms of the surgeries. The basic concept that you need to understand is that there are 2 different mechanisms in which we can make people lose weight. The first one is a restrictive mechanism in which we make your stomach smaller so that it can hold less food than it could hold before. The second one is it's a malabsorptive procedure in which we actually divide the intestine in certain areas and connect it to the stomach. And with that mechanism, we actually make the digestive tract shorter, and we decrease the absorption of food or calories on these patients. These 2 basic mechanisms can actually be combined, and these procedures just happen to be the most efficient ones in terms of achieving adequate and definitive weight loss. So let's talk briefly about these bariatric procedures. Up to now, and up to all this time, ever since I've been doing weight loss surgery, the main procedures that we've been doing is the restrictive procedure, which means make the stomach smaller by using a lap band or a laparoscopic adjustable gastric banding. The second one is the sleeve gastrectomy, in which we make the stomach smaller by getting rid of probably 70 to 80% of your stomach, and it's also a restrictive procedure. And the third mechanism is to do a gastric bypass, which is a combined procedure in which we actually make a small pouch in the upper part of the stomach. We disconnect it from the rest of the stomach, and we bring small intestine to connect to the stomach. What we're achieving here is that we have a stomach that can only hold a very small amount of food, and we have food that goes straight into the intestine without being exposed to the pancreas, to the secretions from the pancreas, the stomach, or the gallbladder, and therefore you're not able to absorb all of those nutrients, resulting in a better weight loss. Well, in addition to those combined procedures that I've always been talking about, we're now talking also about the duodenal switch. So this is the gastric bypass, which is a combined procedure, and the duodenal switch is a 4th procedure that is going to become very popular, and that consists in creating a gastric sleeve as part of the restrictive component of the operation. And then we're going to disconnect the duodenum in this area to allow for the gastric contents or the stomach contents to go directly into the intestine. That will create, again, the malabsorption that we're talking about. And we'll visit again with these lights, and I'm going to tell you exactly what it is again so that we understand it a little bit better. So let's talk about the sleeve gastrectomy. The sleeve gastrectomy basically consists on the creation of a stomach tube, which limits the capacity of the stomach to 60, 80, or even 100 milliliters, which is 2 or 3 ounces. This stomach is usually larger than the one that we create for the gastric bypass. It's a very good alternative to the other 2 procedures that we've talked about. And it can also be used as the first stage to a potential 2-stage operation. This procedure can be converted to gastric bypass in the future, and it can also be converted to a duodenal switch that we're talking about now. So this allows for a very easy conversion from the gastric sleeve to the bypass. And it's also a very important procedure on patients who have had a lot of intra-abdominal surgeries, bowel resections, colon resections, hernias, because this procedure allows us to just focus on the upper part of the stomach without having to go down and take adhesions, small bowel, and mobilize any other of the abdominal organs. This procedure has actually become the most popular one of the weight loss surgery procedures right now. Now, when I said that it's a restrictive procedure, we need to also mention that it may have a hormonal component. And it's actually thought that by the fact that you remove this upper part of the stomach, which is called the gastric fundus, you're actually limiting the amount or eliminating the amount of ghrelin, which is a hormone that is produced there, and that has been associated with increasing appetite. In other words, every time that we start to get very hungry or that we haven't eaten, the ghrelin goes up, and finally when you have your breakfast, it will go down. Same thing happens as you start to wait for your next meal. You start to get hungry, and we see that once that you eat your lunch, the ghrelin level goes down, and the same thing happens with dinner. So it's really believed that the fact that you remove this part of the stomach, you're actually limiting the appetite or suppressing the appetite of the patient. And this is a patient with a gastric sleeve, basically a very successful patient. He's 6'4". Unfortunately, I don't think you can really tell. It doesn't look as impressive when you look at the pictures, but he was a very significant change. And also, just as a small parenthesis, when we talk about sleeve gastrectomies, one of the things that we're doing with selective patients is we're doing sleeve gastrectomies through a single incision in the umbilicus. And this picture actually is supposed to illustrate the only scars that you see in this abdomen. You can actually see how she doesn't have any other incisions, and the only 2 incisions that you can see, this is a magnification of this picture, is the surgery that we did through the belly button, plus a little incision that you can't see there either. This is surgery that we're doing with very good cosmetic results. I'm a firm believer that patients are concerned about their incisions. I'm a firm believer that patients want to be, but selective patients want to wear a bikini in the future, and that they're just worried about their scars. So I have actually placed an emphasis on that, and we have done a very good number of single incision gallbladder surgeries, and of course these sleeve surgeries, a lot of them too. So let's talk about the gastric bypass. The gastric bypass is the first one of the malabsorptive, the combined procedures that I'm talking to you about. Like I said, the gastric bypass consists on creating a small pouch in the upper side of the stomach, and it's actually described as the size of your thumb, which would be a little bit scary because it looks very small, but it turns out to be enough to cover nutritional purposes for the patient. The small intestine is then divided about 2 feet from the stomach, and then is being brought up to connect up here. The lower portion of the smaller intestine is then brought up and is attached in the small bowel. Therefore, you have continuity from the food that comes into the stomach, it empties into the small bowel, and it gets exposed to all this other secretion when it connects to the small bowel in this area. So this is the gastric bypass. Gastric bypass has a lot of advantages. I always tell people that the gastric bypass is the procedure that all the other procedures will be compared to. It has been here for a longer period of time, probably 17 or 18 years. It has passed the test of time. It's a very safe procedure, and it results in very good permanent weight loss. So this is one patient with gastric bypass. And again, all these patients that I'm showing, they're aware that their pictures are being shown. They're happy to share this with other patients that may find motivation based on their changes that they've had thanks to these operations. This is actually a couple that I always like to show. They happen to be, I met them before either one of them had surgery. Then they both went and got braces. Then one of them had surgery when they were both having braces. Then they went on to the other one, had surgery. And finally, they both got the braces off. They both had the surgery. And last week, I found out that they had their first baby after 13 or 14 years of marriage. So this is one of my very happy couples that I really like. I'm also very proud that a lot of the healthcare professionals that I work with have given me the honor of operating on them. There's somebody who works in this hospital. There's another person who works here as a nurse practitioner in the ICU. One of my scrub techs who sees me operating, who operates with me all the time, decided to trust me with her surgery. That's the biggest compliment that I can think of. And this is another scrub tech as well that works with me frequently. So let's talk about the second one of the malabsorptive procedures. The duodenal switch, it's actually malabsorptive and restrictive. Again, like I told you, it involves the creation of a gastric sleeve like the one you saw before. It involves the division of the duodenum in this area, because otherwise this would continue with this, so we've divided this. We then go down almost to the end of the small bowel to divide the ileum and we bring this area to connect to the stomach. So now we have a small amount of food that the patient can take that goes directly bypassing a lot of the small bowel that is exposed to the biliary and to the pancreatic secretions. And this results in malabsorption and excellent weight loss. The duodenal switch is mostly used on patients with super obesity, body mass indices of more than 55 for the most part. But it's definitely the procedure that is better indicated for the resolution of diabetes mellitus. This is the one that we're going to start hearing that is recommended if you're really trying to resolve and improve the management of diabetes. It usually results in a higher weight loss and sometimes in a higher malabsorption as well. So what I tell patients, just look at this duodenal switch. We're starting to do it. It's been done for a long period of time, but I think the more that we do gastric sleeves and the more that we start to focus on the management of diabetes, we're going to see it grow and it will become very, very popular. Finally, let's talk about the lap band system. The lap band system is the second one of the restrictive procedures, and I have actually elected to leave it for the end. I used to always, until today, talk about it at the beginning. The lap band, I think it's a good procedure. I think it works. Unfortunately, it doesn't work as much as we would like for it to. It doesn't take the patient to their ideal weight or ideal body mass index that we would like for it to go. And in the long run, it has resulted on patients who need to have their lap band removed because of complications or even because of failure to lose weight. So this procedure, unfortunately, is not as popular as it once was, especially now that we have the gastric sleeve. Basically, what the lap band involves, it involves the placement of a silicone band that is placed in the upper part of the stomach. This results in a small pouch in the upper part of the stomach. Therefore, the stomach can only hold a limited amount of food. And at a certain point, it actually helps the patient with achieving early satiety and eating less. It's usually an outpatient surgery, and it is usually a shorter operating time. The weight loss that you achieve is actually good. Some patients actually lose 1.5 to 2 pounds per weight. They're usually able to eat most solid foods, and they usually don't have any limitations in terms of the liquid that they can take. When I say adjustable, it actually refers to the fact that it has this tubing that connects to a port that can be accessed to make the stoma or the inside of the band smaller or larger, like you will see. So when I say that we actually adjust these lap bands, we basically try to look into this green zone for adjustments of the lap band. We want to have the patients very happy on the green zone where they're achieving adequate weight loss, they're not hungry all the time, and they're just very happy. If we notice that patients are hungry between meals, they're eating big meals, and they're looking for food, they're not going to be that happy, and then we have to adjust these bands. On the other hand, if the patients are having problems with not being able to swallow, not being able to eat very well, refluxing or vomiting, the band may be too tight, they're going to be unhappy, and we have to deflate those bands to make it bigger. So when I talk about the adjustment, this is basically what we do. The port that you access right here, this is an empty or deflated gastric band. This is an inflated gastric band, and you can see how the inside gets affected. You also need to consider that in between this, the stomach wall is going to be inside. So you really limit, you can actually completely close the communication between the upper part of the stomach and the lower part of the stomach. And you can actually make all these adjustments through this port. And this is one of my very successful lap band patients. I love showing her pictures because she's always very happy, and she has been very successful down to 5 years down the line, and I think she's been to some of our support groups as well. And when I talk about lap bands, like I told you, one of the problems and one of the things that we're seeing is that some of these patients are being converted from a lap band to a gastric bypass. In fact, we're starting to see a lot of these revisions when we remove a lap band, and slowly, steadily, we see how the patient weight starts to go down when we convert them either to a gastric bypass or even to a gastric sleeve. And we're seeing better results and probably less symptoms when we do that. So with all this information that I'm giving you, the question is going to be, so which one of these procedures should I get? So my answer is going to be, you need to get the one that you want. But you want to come to the seminars, you want to talk to your friends, to your coworkers, to your relatives, to anybody who has had surgery, so that you can actually make an informed decision. I'm not going to convince anyone of which procedure to have. The choice is going to be yours. But I'm going to give you certain recommendations as to what I think the best procedure is for your particular situation. But I definitely strongly recommend that patients talk to other patients and attend support groups just in order to be able to make those decisions. The 4 recommendations that I'm going to give, and this is a slide that I just created as I was thinking about this presentation. As far as I'm concerned, I wouldn't recommend a lap band unless there's another option. Okay, I think if you're definitely not going to be willing to have any other procedure, I think a lap band is better than no surgery. We'll do it under those circumstances. But knowing that we have gastric bypasses and gastric sleeves that can be done with better results, better weight loss, less maintenance, no foreign body, and decrease the risk of the long-term complications, I'm really going to recommend that you go for one of those before you even consider a lap band. Now, when we talk about the gastric sleeve, if anybody wants to have a gastric sleeve or a gastric bypass, I'm completely in agreement with that, as long as the patient doesn't have gastroesophageal reflux or heartburn. Most of the literature that we're seeing is telling us that every time that we do a gastric sleeve, the pressure inside of the stomach goes up, and the incidence of reflux is going to go up. So we want to make sure that we're not going to have patients that are going to have worsening of their symptoms with reflux, and we're going to end up having to convert them to another procedure in the future. So if I can avoid it, I will persuade you from having a gastric sleeve if you have severe symptomatic reflux. Finally, if you're a diabetic patient, gastric bypass or duodenal switches are going to be the treatment of choice for that. So with that being said, I always get the question about the comparison about one or the other procedure. And the slide that I've always had is basically to talk about the length of time for the operation, with gastric bypass taking about 1.5 hours to 2 hours. Patients with gastric bypass and gastric sleeve stay 1 night in the hospital. The lap bands are usually done as an outpatient. Recovery-wise, I say 2 weeks for every patient. I recommend that the patients go back to work 2 weeks later, unless their work involves physical activity, pushing, lifting, and so on, in which cases I recommend light duty until they complete 6 weeks after the operation. In terms of complication rate, instead of giving you numbers or percentages, I've decided to say that the lap band is probably the one with the least short-term complications. Gastric bypass, it's a little bit more complex operation and can have more complications, and the gastric sleeve is probably also very benign in terms of complications. The mortality rate is very, very low for all of them. I think even 1% and 0.5% is very high. You know, in fact, in my series, which is more than 600 cases, I've never had a mortality, knock on wood. But that's just not to say just about me, but that's what we're seeing. We're not seeing mortalities in these patients unless something absolutely strange happens. In terms of weight loss that you can expect, gastric bypass, you'll achieve a weight loss of 77% of the excess body weight, or I'm sorry, of the excess weight. And with the gastric sleeve, you'll achieve 70%. What that means is that if you're overweight by 100 pounds, you'll probably lose 70 of those pounds in the first 2 years with the gastric sleeve and 77 with the gastric bypass. And this is the one slide that I definitely didn't have ready for today. I spent a lot of time working on it, but then at the end, when I wanted to change the colors on each one of these to make it a better comparison, I just couldn't do it. Basically gives you all the information that you want to have, including the duodenal switch, and I'll eventually be working on that. If somebody has any specific questions, we'll talk about them at the end. So the basic principles, regardless of which procedure you choose to have, is that you will feel more satisfied with a small amount of food. You can continue to eat healthy at home or away from home or even at restaurants, but you have to be selective on what you eat. You have to make wise menu choices, and you need to make better bad choices. And this is just another example, just to catch my breath and show you my scrub tech who has had very good results. So a little bit about the potential risks of bariatric surgery. Of course, we couldn't be considering or talking about surgery without thinking that there may be some unwanted effects, complications, or side effects. And some of these, what I've definitely decided to address, a lot of the complications and a lot of the risk actually can be abolished with this aggressive prevention. So if we can have problems with anesthesia, but they're extremely rare. We can have problems with pneumonia, but for that we actually give the patients an incentive spirometer, and we encourage them to get up early, to take deep breaths, and we have been able to minimize the incidence of pneumonia. In fact, I don't think I've ever had a patient with pneumonia after one of these operations. Blood clots is a very well-described complication on patients with obesity who are in the operating room for a long period of time. We use blood thinners before and after the surgery, and we use what is called sequential compression devices to stimulate the circulation and to increase the breakdown of those blood clots. And again, we haven't had any blood clots, knock on wood. Finally, wound infection is probably more common on gastric bypass because of some of the technique that we use, but overall the complication rate is actually very low, and obviously we use a perfectly sterile technique with the assistance of intravenous antibiotics as well. So when I talk to patients about the risk and possible complications, I always tell them, please try to make your decision on the procedure based on the benefits that you're going to get. The risk exists, but they're actually small. The benefits are huge, and that's what you really need to focus on. So going back to what I want you to know, why do I do surgery for obesity? I do surgery because I get these quotes. I can now play and compete with my high school students. He used to be a football coach who could barely walk, sit, squat, or run. I fit in my old clothes and I feel better with myself. I can ride a go-kart. I feel much better when I go to work or exercise. I'm only taking one of the 8 pills I used to take. And these and other quotes that I keep on hearing. To me, this is very gratifying, rewarding to be able to participate in a positive change of life for these patients. I can cross my legs, things that we give for granted. I can tie my shoes, so many other things. So when you look at the final outcomes of weight loss surgery, you actually see how 95% of the patients report significant improvement in their quality of life, body image, personal hygiene, sexual function, employment, professional advancement, and so on. But the key to this is to always keep in mind and to always remember that the bariatric surgery, it's just a tool. It's not necessarily the cure, it's not necessarily magic, but it's only a tool that is going to assist us with achieving this weight loss that we want. So this is one of my nurse patients that I operate on. I order medium scrubs and they actually fit. Rock on. So with that being said, with all this being said, how do I know that I qualify for weight loss surgery? Well, some of the things that we may suggest for you to consider weight loss surgery is, if you don't have any other disease that could have caused you to be overweight, if you're willing to change these eating habits, and if you're willing to have these changes in your lifestyle, then we believe that you're going to be very successful. We always propose that you get prepared to attend regular follow-up sessions and that you continue to follow up in these aftercare and support groups. So finally, what I want you to know is, what are we going to have to do so that we can get you to the operating room, so that we can get you to have your weight loss surgery? Well, when you come into the office and we have your surgical evaluation, one of the things that we're going to see, we're going to talk about your body mass index, which you already know at least the basics of it. We're going to talk about what your ideal body weight is, and we're going to compare it to your real weight as it is the day of the office visit. That number will give us your excess body weight, and that way I'm going to be able to tell you how much weight you can expect to lose in the first 2 years. Now, regardless of how much you weigh, every one of the patients will be asked to lose weight before the procedure. And this is something that everybody is trying always to emphasize. Whenever we're going to have the surgery, we ask you to lose the weight because we want to make your liver shrink. Every time that we go in there, whether we're operating a lap band or a gastric bypass or a gastric sleeve, we have to make your liver smaller because we're going to have to lift it up so that we can work there. And every time that we gain weight on our cheeks, our waist, our hips, and the same thing happens to the liver. The liver gets bigger. So in order for me to be able to operate on you, I want to make you lose weight. And we've seen that if you lose 10, 15, 20 pounds, your liver will be smaller and will be able to have access to this part of your upper abdomen. So that will be the first condition. In addition to that, we'll need some additional workup, which is going to help us assess your overall status, overall condition, and from there, be able to plan a better and safe surgery for you. So everybody, just for coming into the hospital and trying to get an evaluation, is going to need to have some blood work. We're going to do a complete blood count, and we're going to be able to identify problems like anemia, low platelets that may impair your ability to clot. We're going to look at comprehensive metabolic profiles, trying to look at your liver, your calcium, your kidneys, hemoglobin A1C. If you're diabetic, we want to know how the management of your diabetes is going. And if you're not diabetic and we find out that your hemoglobin A1C, then it's time to start looking at also managing the glucose or the sugar. We do an HIV test on everyone. We do a thyroid profile, and we monitor lipids and cholesterol. As part of the workup, I also like to do a gallbladder ultrasound. We know that patients who lose a lot of weight tend to form stones, and they can have problems in the future. We also know that when we alter the anatomy, like we do with the gastric bypass and with the gastric, and with the duodenal switch, we may not have access to treat problems like gallstones if they decide to migrate into the biliary tree. So we try to prevent this, and if we identify that the patient has gallstones, this is a beautiful ultrasound where you can see an empty gallbladder, and here you can see some of this shadowing created by the stones. So if we find that somebody has gallstones, we're going to recommend that you get your gallbladder removed at the time of surgery. In certain selected patients that may have some criteria for sleep apnea, patients who snore persistently, patients who have restless sleep, morning headaches, night sweats, they fall asleep while they're working, they fall asleep while they're driving, they wake up gasping for air. Some of these patients may have sleep apnea, and sometimes we recommend that you get a sleep study in advance. If we can diagnose that you have sleep apnea, first of all, we'll recommend that you get a CPAP machine, and we're going to ask you to use it around the time of your surgery, just so that we can keep you from having respiratory problems and have a safer surgery. But at the same time, this may be something useful for your insurance to know, and they may say, well, this patient is obese, and he has diabetes or high blood pressure, and then he also has sleep apnea. So that may be another criteria that will facilitate the decision process for your insurance to get you approved for surgery. Most of the patients will require to have an upper endoscopy. An upper endoscopy consists of going inside with a tube in which we can actually inspect the inside of the stomach. We look at the junction between the stomach and the esophagus, and we want to make sure that you don't have ulcers, tumors, before we go in there to do anything to the stomach. One of the things that we like to look at this area in particular where the abdomen is actually divided from the chest by this muscle that is called the diaphragm. We've seen, or we know, that whenever the stomach actually migrates into the upper part of the chest, this is called a hiatal hernia. It's very common in obese patients, and it's very common that we have to repair these hernias at the time of the surgery. So this is some of the information that we want to know. Now, in addition to your preoperative workup, coming to see the bariatric surgery or bariatric surgeon, which hopefully will be me, will be important. We will be referring all these patients for a dietary evaluation, and we will start the counseling of the dietary by the dietitian at that point. We'll start the weight loss that I'm asking you for in order to make that liver smaller. All the patients that we operate on require a psychological evaluation. Many of the insurance companies require it. We just decided that the best way to achieve good results is by having patients be interviewed in advance, make sure that we're able to identify any type of psychological, psychiatric problems, or even eating disorders. And then, depending on your particular medical history, we may decide that you need to have clearance from your cardiologist, your lung doctor, your gastroenterologist, your rheumatologist, or whoever needs to be involved in the clearance just to make your surgery safer. So just going back to some of the quotes and some of the texts that I received, I shared this with you. I thought I looked good a year ago. Now I know that I look really good. Keep up the good work, and once again, thank you. And this is one of the most recent ones that I received. Somebody who went to her closet and was able to wear her prom dress from 11 years ago. So I'm happy that they shared these things with me, and I'm happy that I can be part of this positive change in their lives. So like I said, like I always tell, I have a collection of pictures of every 100 cases that I've done. Unfortunately, I haven't updated it, but you can see the 400, the 500, the 600, and hopefully we'll keep on growing with all these pictures. At the end of the day, what we're trying to achieve with this weight loss surgery is that your health improves, that you improve your quality of life. Hopefully, you will be obtaining an increase in your lifespan, and the additional bonus of cosmesis, which is, it's really a bonus, but it's a very valuable one. Finally, to conclude, the surgical treatment of obesity is definitely safe. It's a definitive option, and it always results in an improvement of your health and your quality of life. We are firm believers that weight loss surgery demands a commitment, it demands a change of life, it demands a change on eating behaviors. And lifelong support is offered and is strongly recommended. And if you come back and see me after surgery, you'll always get the question, are you going to support groups? Are you going to aftercare groups? I think it's very, very important. So final word in one other satisfied patient, some other satisfied patients, which will hopefully make it to all those fancy slides that I presented earlier. And finally, you know, just a few words. More changes are coming. We're talking about duodenal switch. We're talking about robotic-assisted surgeries. Some of the surgeries that we're doing for revisions and some of the surgeries that we're doing for gastric sleeves, we're doing with robotic surgery. So there will be more to come. You know, we're always learning. We're always trying to adapt new technology. And we hope that that will result in better outcomes for the patients.